Hi, Dr. Moses.
Hey, Darryl, how are you?
I'm good. Hope you are too. Tough times, but we're doing what we need to do.
Yes,
Uh,
sir.
yeah. Welcome to our conference. We're really grateful for you to be here. Can you tell our audience, everyone watching, what kind of doctor you are and where you practice?
Sure. Well, thanks for having me first. Really appreciate it and look forward to the conversation. My name is Kelvin Moses. I'm Associate Professor of Urology at Vanderbilt University Medical Center in Nashville, Tennessee. I primarily treat men with advanced prostate cancer with a focus on clinical trials, and also serve as the director of the Comprehensive Prostate Cancer Clinic based here at Vanderbilt.
So, like in a given week, how many days a week do you actually see patients in your office?
I see patients in clinic 1.5 days a week, and then I operate 2 days a week.
So, and you've had patients who were newly diagnosed as well every now and then, is that right?
Every once in a while, yes.
So let's start, and we're going to be talking about guys in advanced stage prostate cancer, but it's interesting to know what guys come into your office who are new, the difference between what your impression is in a general way, everybody's unique, but in a general way, guys who are newly diagnosed versus guys who have already gone through an initial treatment, but now their PSA is elevated, they're concerned about metastases, perhaps already been scanned, and they're sitting in front of you yet again.
Mm-hmm. Well, the one thing for men who are newly diagnosed, there's always a lot of questions like, well, what is the prostate? What does it do? What's its function? Am I going to die from prostate cancer? What are my treatment options? Am I ever going to have sex again? Those are kind of the initial thoughts. I can only imagine, with a diagnosis of cancer of any type, and in particular prostate cancer, how is this going to affect my life? How am I going to function? They have if they're married or have a spouse or partner, like how's it going to affect them and our relationship? And so there's a lot of, not necessarily confusion, but certainly a lot of questions about how their life is going to be impacted. The one thing I try to impart from the vast majority of men who are newly diagnosed localized prostate cancer, it's not something they're going to die from. And so we sort of reassure them, go over all their treatment options, and then talk about how their life will change and how we can try to make it as best as possible, try to optimize their quality of life.
And so for for guys with advanced stage, they're coming in and either they're seeing you for yet another time, or they're seeing you because somebody else has referred them to you as an advanced stage expert.
Mhm.
Um, I mean, is there? I mean, what do you think's going on in their heart and in their head at that moment that they walk in your office?
If they're seeing me in my clinic, they've got advanced disease. And the first thing they ask, or they want to know, they may not ask, but they're wondering, am I going to die from this? And they are at high risk of death. If you have metastatic disease, if you have hormone resistant disease, those men we have to treat aggressively when appropriate. And then the other thing, again, it goes back to quality of life. Men, even if they know there's a risk of dying of cancer, they don't want to die with, or live with a lot of pain. They don't want to have so many side effects from treatment that they aren't able to do the usual activities of life. So really, I think longevity and quality of life are at the forefront. And then they want to know, okay, well, what are my options? What are the side effects? What are the sort of umbrellas that these different types of treatments come under? And then we can get into more specific details. But really, longevity and quality of life are really kind of the focus of most men who are coming in.
Yeah, and it's okay to talk about, like, am I going, or ask, am I going to die
Mhm.
tomorrow, or
Right.
am I going to die in pain? You
Mhm.
know, I mean, these, you know, doctors who treat advanced stage people are treating advanced stage people knowing full well this is now the new struggle that you're doing.
Mhm.
You
Yeah,
know, yeah,
absolutely.
yeah,
And we have to be sensitive, you know. I always have an idea of what somebody's survival is based on prior trials or my experience with patients. And so I want to be honest with them, but I also want to emphasize, you know, with the treatments that we have now, their survival is significantly longer than it was just a few years ago when we did not have as many options. And so, you know, if I can kind of convince them, hey, we're buying you some more time and we're trying to preserve as much quality of life as possible, that's something that patients can kind of take home with them.
yeah. And it really is an exciting, last couple of years. I mean, as we enter 2021, I mean, who can even begin to imagine what's available to us? I mean, news
Mhm.
is taken up with COVID discussion and vaccines, but there's really new molecules that are being worked on and wonderful trials that are, that these molecules, these opportunities are being checked into. The idea that patients have sometimes is, I don't want to, is that if they express to the doctors, I'm going to worry about, I don't want to be in pain, I don't want to feel X, Y, or Z, that would sort of cause the doctor to negate some of the possible treatments.
Mm.
Um, I mean, is that mythic, or is that really a
No,
practical?
that's definitely realistic. And that's why when we talk about each treatment, we have to be very specific and detailed about the side effects. Number one, just so there's no surprises. And number two, kind of give them a realistic set of expectations, and really what we emphasize are goals of therapy. So there's plenty of treatments that I have available, and I'll tell patients, hey, I think this is something you could tolerate well because you're in good condition or you're at the right age, or you know, maybe even have had it before. But then if there are treatments that I think will hurt patients, I'll tell them, I say, look, I think this treatment is going to do more damage than good. And even if it helps you live a little bit longer, it may not feel worth it to you because the side effects are so significant. And so that's where the communication part is very important. When I'm discussing with patients, I try to get an understanding of what their goals are initially. I always give all the options, but then I can tailor the discussion to what the understanding of what their goals are, and then help them make their own decisions. I never tell patients this is what you should get. I can give a recommendation, but I always leave it in the patient's hands because you know they know themselves the best.
Yeah, and it's sort of a paradox, the quandary of, there are a lot of things that we could do, and you could choose what fits you, Mr. Patient.
Mhm.
But patients also say, what the fuck? I mean, I just want the best thing for me. Surely you could tell me what the best thing is for me.
Sure, and that's where that's where I say this is my recommendation. And I think this is the best treatment as far as improving in survival, managing side effects, and I want to make it personal. I would say, this was me, or this was my dad, this is probably what I would consider. um, and I always say there's really no magic bullet, there's no perfect treatment, but sometimes there is that one or two best things. And then again, kind of let the patient decide, hey, I think you're right, doc, let's go with this. Or, hey, doc, I want to minimize this particular side effect, so let's think about this alternative. But we as physicians, we have to avoid saying, this is the one right thing and you have to do this. But it's still okay to give a recommendation.
Yeah. Let's spend the next 90 seconds to 3 minutes or so just getting everybody on the same page vocabulary wise. Is it castrate or castration resistant?
It depends on who you ask.
Ah,
It's
okay.
probably, yeah, it depends on who you ask. You can look at the guidelines and look at different papers, and I've probably used it interchangeably. It's probably more correct to say castrate resistant. Um, Castration, that means the physical act of removing the testicles, whereas castrate state means that their testosterone has been reduced either medically or surgically.
So
But
we're all castration resistant. We all don't prefer not to have our testicles removed.
yeah, but sometimes
And
removing the testicles is a good option.
yeah,
We do that.
and in fact, within our support groups, and like now that everybody's online, and you probably we've got like 76,000 people actively online right now.
Mhm.
Orchiectomy comes, the process in the surgical procedure to remove testicles is coming up a lot more frequently than
Yeah.
ever we've seen in a positive way. You know,
Yes.
yeah.
Yeah. We offer it to patients, and what I tell them, so the whole reason for castration, whether surgically or medically, is to reduce that testosterone level because testosterone feeds prostate cancer. And the comes with side effects. Those shots that people take to reduce hormones, people can get hot flashes, they can get fatigue, they can get weight gain, and it's also expensive. I mean, for the most part, insurance covers it, but there is an out-of-pocket cost. And so, orchiectomy is actually pretty favorable. Number one, you don't have to get shots, and so it's actually very cost effective. And even though I don't know of any literature that backs it up, the men who have had orchiectomy don't have the huge waves of hot flashes and cold chills. Like it seems to be tolerated a good bit better. And so, yeah, we offer it to men. And the idea, it sounds sort of medieval, right? I'm gonna cut your testicles off, but when you explain it appropriate and kind of the long-term risk and benefit of it, it's actually a very attractive option for men.
Yeah. So we're talking about advanced stage. How do you sort of identify a guy and say you're now advanced stage?
So that's a great question. And what we do is categorize men based on if they have metastasis or not, meaning spread of disease outside of the pelvis. And then are they responding to hormone therapy or not? So are they hormone sensitive or castrate resistant? And so then if those are the two categories within each of those, then there's sort of four different states, right? So you can have metastatic hormone sensitive disease. So that's the man who walks in off the street right off the bat has metastatic disease. Then there's non-metastatic castrate resistant disease. So those are men with a rising PSA despite being on hormone therapy, but no evidence of disease outside of the pelvis on imaging. And then there's metastatic castrate resistant. And those are men who have spread of disease outside of the pelvis and are no longer responding. And all of those men, are put under the umbrella of advanced prostate cancer. And that's beyond men, let's say a man who's had primary treatment and then had recurrence of their PSA. That's called biochemical recurrence. We don't necessarily put them in that advanced stage because it could just be, a slowly rising PSA that for the most part we can watch safely, or you can treat with hormone therapy. But once they progress beyond that, those are men with advanced disease.
Yeah, and good last point around the rising PSA after primary therapy. I mean, in essence, everyone after after surgery or radiation, on initially diagnosed kind of thing, is ideally doing a watchful waiting kind of
Right,
stance,
right.
and not to freak out if your PSA is rising. Of course, those numbers look much smaller than they did before you were diagnosed. They're in the decimal point kind of thing.
Yeah.
Another thing, just before we get into the actual therapies, the idea of ultrasensitive PSA versus other PSA. What are in the advanced stage realm? Like, what are the variety of PSA tests, or how should patients understand those?
Yeah. The role for high sensitivity or ultrasensitive PSA in the advanced state, it probably doesn't have a lot of utility because, if a man has a PSA of 0.03, you don't necessarily consider their risk of metastasis is minuscule, probably 0. And that means they're still responding to hormone therapy if they're on it. So I don't necessarily use ultrasensitive PSA. At our center, the lower limit of detection is 0.1. In some places, it's 0.06. But again, even at a detectable PSA, we still have to track the velocity or doubling time. How long does that take? How long does it take for that PSA to be twice what it was before? And then you need 2 or 3 consecutive rises in PSA to determine that it's truly rising. So I don't necessarily use ultrasensitive PSA very much. People do use it in the setting of after primary therapy. After a surgery, your PSA should go immediately to undetectable within, 6 weeks to 3 months. Whereas if you have radiation, it will sort of slowly come down over time. But in those instances, ultrasensitive is nice because you can detect recurrence very early. And if men are considering salvage therapy, then they can get it done while the PSA is still very low and still have a reasonable expectation for cure.
Yeah. And, ultrasensitive, it sounds like, within a support group setting, guys are saying, why wouldn't you do the better, more precise test?
Mm-hmm.
And there's an art to all of this. And that's why
Mm-hmm.
engagement with a really good doctor is like such a big deal. It's critical. It's as much a part of your care as, what drugs to take and such.
Sure.
Let's now talk about guys are showing up in your office. They've either been referred or they've been your patient for a while, and you've seen scans that evidence some metastasis or something suspicious or something, but their PSA has gone up, et cetera. The typical guy in a support group is going to tell us that his doctor said androgen deprivation therapy.
Mm-hmm.
Is that still like just the only thing people are offering now, or in 2021 has it become more interesting and more complex?
So there's definitely use androgen deprivation. Excuse me. That's sort of your baseline management. So just about every man with advanced prostate cancer is receiving androgen deprivation of some sort. But in all the states that I mentioned before, metastatic hormone sensitive, non-metastatic castrate-resistant, metastatic castrate-resistant, there are additional therapies that we use on top of androgen deprivation that have all shown an improvement in overall survival, or at least an improvement in the time before metastases show up. So I would say the vast majority of men, again, if they're in good condition and tolerating therapy, are on some sort of combination. You can do androgen deprivation monotherapy, meaning only that. If particularly someone is very old or has a lot of competing comorbidity, illness that may kill them before cancer does, then sometimes we would just use monotherapy. But again, for the majority of men, they're on some sort of combination.
And what do those combinations sound like? I mean, there are people sitting around with pen and pencil right now.
Sure.
Yeah.
Yeah, so the combinations kind of fall under 3 or 4 umbrellas. One umbrella is hormone therapy. And the vast majority of these are pills that you take. They're called second generation anti-androgens. These are pills that you take in addition to your hormone shots. There's several of them. They all end in amide: enzalutamide, apalutamide, darolutamide. And so that's one class. And then there's also another drug called abiraterone, which is known as Zytiga. And that again is an oral medication that's used in combination. Then there's the umbrella of immunotherapy or vaccine therapy, and that would be Sipuleucel LT, is known as Provenge. And that's for men with metastatic castration-resistant prostate cancer without symptoms. And then there's chemotherapy, and that is a drug called docetaxel or Taxotere. That's typically used for men with more advanced disease or symptomatic, but there are different categories that it can be used in. There are new drugs that are called checkpoint inhibitors and PARP inhibitors. And these are men that have specific, or they're recommended in men with specific genetic mutations. And all men who have advanced prostate cancer should get genetic testing and genetic counseling, because there are drugs that are specific to certain mutations. And then sort of another umbrella would be radiotherapy. So there are either radiation to specific areas or radiation infusion. There's a medication called radium-223 or Xofigo. And that's primarily for men with bone pain and bone metastasis without other metastasis. So just to kind of review, there's anti-androgen therapy, hormone therapy, immunotherapy, chemotherapy, PARP inhibitors and checkpoint inhibitors, and then radiotherapy.
So I can't tell you how perfect the last 2.5 minutes have been. I mean, really, there's so many presentations and so many consultations that we hear about where all of that is just jammed into one little sentence almost, you know, or syllable here, a tone there, and nobody knows what's going on. The idea that there are 5, let's say, columns of opportunity for, how do you, so thank you for that. That was really good. And I'm sure, like everyone in the audience, sort of, the 1,000 virtual people sitting behind me, really, and they'll have the opportunity to replay this. So very good. But now that we have that sort of clearly sort of visualized and outlined, whether we know how to spell any of these things or not, but what's the conversation between patient and doctor like around these 5 different kinds of things to do?
So that goes back to the categories that I talked about. And so because there's all these treatments, and I forgot to mention even before, clinical trials, right? So there's even clinical trials that could encompass any one of those therapies or other novel. But what we use are the guidelines. And so the AUA has guidelines, NCCN, National Comprehensive Cancer Network, has guidelines. And basically there's an algorithm that we follow. And so again, we look at what category men fall under. We also look at whether they have symptoms or not. We look at whether they've had chemotherapy before or not. And we also look at the burden of disease. Do they have a lot of spread in lots of different places? Is it just bone? Is it mostly in lymph nodes and organs? So once we kind of fit that box of, hormone sensitivity, location and number of metastases, symptoms, and chemotherapy, then we can say, okay, within this category, we have the following 3 or 4 options, and say, okay, we have this one, this one, this one, this one. And for each one of those, we can talk about here's the benefit in survival. Here are the typical side effects. Here's the average length of time that people are on medication. And then here's maybe some other things that we can try if this particular drug does not work for you, or we can use one of the alternatives. And so my conversations can be fairly detailed. So I'll write things down or give them some information. And my clinic is not like my surgical clinic where I can get through stuff in 5 or 10 minutes. Like, I'm actually sitting down and, it may be 15 minutes, it may be 40 minutes, but it helps to have that algorithm, because I can say, okay, this is the category you fit in. Here are the drugs that are already approved and available. Here's potentially the clinical trial that you would also fit in as well. And the benefit of a clinical trial is everybody is getting the standard of care, and then one group is getting a novel therapy or drug compared to the people who are just getting the normal standard of care. And so those are all the options that we go through. And again, we look at how a patient is doing overall. What's their performance status? What did this person get wheeled in here on a stretcher and they can barely talk and they're getting fed through a tube in their stomach? Or, did they just come off of a 5-mile jog before they came to clinic? And that too plays a role in what kind of decisions that we make for patients. But using those guidelines, using that algorithm really helps to clarify, where patients are and what their options are.
Yeah, and it's adjustable too.
Absolutely.
If something's not working, you change, you flip
Right.
into something else.
Right.
And is it fair to say that by having all these options and knowing that you can be flexible depending on the patient's responses and desires and goals and experience, you really have the opportunity to extend to a very long lifetime. More than days, weeks, months,
Yeah. Yeah, I would say most of the men are looking at years of survival, even with metastatic disease. Now, if they have metastatic disease and castrate resistant and have been through multiple lines of therapy, their time is probably getting short. And in those instances, again, clinical trials are important, but also palliative care, right? And it's not necessarily just for end of life, but really discussing goals of care, minimizing or managing side effects. Our palliative care colleagues are very adept at dealing with those type of issues. But for most of the men, when they come in, especially their wives or a partner or daughter or son are sitting next to them, I always lead off with, hey, you're not going to die tomorrow. You're not going to die next month. You probably won't even die next year. And that's probably not what they were expecting to hear. The idea of metastatic cancer, you hear about celebrities or somebody that died of cancer, that kind of sticks in your head, but we have to be realistic about, what your true survival could be. I'm always giving averages, and I say, most people live between, 2 years and 5 years, and you probably fall somewhere in the middle. Because nobody, who knows the day and time. But there are also times where I can see how people are progressing and say, this disease is rapidly progressing. Our time may be short. Or somebody who's been on therapy with undetectable PSA for 5 years, they'll probably live, several years. But we can always give somebody a realistic number of what we would expect for survival.
Do you see disparity issues come into play at this stage of cancer? We know in our organization, we have the twice as many program referring to prostate cancer killing 2.4 times as many Black men as it does white men, and Black men presenting usually with, I think 60% this year, higher percent of advanced stage the initial presentation. Does response to therapies at the advanced stage level have greater benefit for white guys than Black guys?
That's a great question. I'll say in general, we don't know because unfortunately clinical trials usually do not have adequate numbers of Black men in order to come up with a good conclusion about that. But interestingly, over the last couple of years, there have been a few trials that had a good number of Black patients, and they've actually shown better response in Black men compared to white men. And in particular, I'll talk about Sipuleucel-T or Provenge, has shown that therapy had a survival benefit in all men below a certain PSA, but Black men actually had even greater, significantly greater survival compared to white men who had received Provenge. Similarly, for abiraterone or Zytiga, some of the more recent trials have shown that Black men may have even greater improved survival. So the disparity that we see in Black men with prostate cancer overall starts very early on, where men are less likely to get screened, less likely to get treatment. And so they end up in my clinic because they have advanced disease. But some of the options that we have, there is data that shows that Black men can expect similar, even greater survival benefit.
Yeah. I read the study, Oliver Sauter. Yeah, I mean, it's not just like a little bit, it's like an extraordinary
By
bit.
about, depending on the PSA level, it can be up to a year and a half, 2 years greater benefit.
Yeah. Yeah, much more stuff needs to be done to understand that. What do you do with patients who come in saying, I want an integrative or complementary approach, or, I've lived my life, vegan, vegetarian, whatever. What can you do for me without these invasive chemical thingies?
Sure. Yeah, that I hear that a lot. And I try to be very sensitive about that because that is definitely a lifestyle that people adopt, and that's what's worked for them. I always encourage a healthy diet. I always encourage physical activity. So if men are vegetarian or vegan, as long as they're getting their appropriate nutrients, I'm all for that. I have men that ask about, marijuana or CBD or something, to help with manage pain. I'm all for that. That's great. I cannot give them recommendation and say, yeah, I think that, mega doses of vitamin C are recommended for you, and you can do that instead of what I can offer. Because number one, I don't have the literature that says that mega doses of vitamin C, or I'm just using that as an example, but, is going to help you live longer. You're welcome to do it. If you do it in place of what I offer, I can't tell you what your survival is because I don't have any data or literature. I can only give you specific numbers based on the information I have. I have had several men who have declined all therapy, and I think that's fine because, again, it's a personal decision. Their disease does progress fairly rapidly because, this is a hormone responsive cancer, and without hormone therapy, it's free to grow rapidly. And so I'm all for complementary. If in addition to what I offer, you want to do cranberry therapy or coffee enemas or megadose vitamin C, I've heard all kinds of things, pomegranate juice, whatever. Happy, you can do that. But if that's the only thing you want to do, we have to understand that disease can progress rapidly. There can be pain, and you can get to a point where I don't have many or any treatment options for you. And so just to have an understanding of that.
Yeah. In the time we have remaining, I see the clock winding down a bit. The idea of most of these interventions, these opportunities are injections or pills, or, with Xofigo, it's a radiation kind of injection, an isotope thing. I think, is it an isotope? No.
Yeah, it's isotope of radium 223.
Okay. See, all of these seem benign compared to surgery or radiation therapy on initial presentation, like, so, over like in the last 5 or 6 years, we've heard a lot of people come up with what at first glance seems wisdom. Why not just offer this level of treatment on initial diagnosis?
That's a great question, and there are people doing that. So you remember I talked about Sipuleucel LT or Provenge. There is a trial where men with very early stage disease who are eligible for active surveillance get randomized to either receiving Provenge or not as part of their active surveillance protocol. We actually have that trial here at Vanderbilt. And so, yeah, that's a drug that we've taken all the way from metastatic castrate-resistant to the very early stages of cancer. And I would, as more and more men get genetic testing, I would imagine that some of the drugs that are specific for, let's say, the breast cancer gene, which has shown to confer aggressive prostate cancer in men, that drug that we could give for advanced disease, if we know at early stage disease, if we give them those same drugs, can it prevent recurrence? Can it increase the amount of cure? So that's a completely reasonable thought. The way clinical trials and phase 1, phase 2, phase 3, you sort of start at the extremes and work your way backwards, because a lot of these drugs do have side effects. And so you don't want to harm men who have potentially curable disease unless you know that there's a benefit, in other more advanced populations. But yeah, there are definitely trials that are marching these drugs sort of back. Another trial that we're running here called the Proteus trial, where one of the oral medications that we use for advanced prostate cancer, we give for men who are eligible to get a radical prostatectomy for high risk localized disease. So again, that's another drug where it's approved for more advanced disease, but they're studying it at earlier time points. Again, can you improve the rate of cure? Can you prevent recurrence for a longer period of time? So that's definitely happening.
Yeah. And finally, well, actually, let me just, before we get to the final part, I mean, what else that I haven't asked about or suggested, what do you think is important for patients and their families and friends, if they have any, and for single men?
Mhm.
I mean, from your extraordinary experience with these guys, what should they be asking? What's missing? What did you and I not discuss that you think is important?
Well, again, so I want to emphasize, the importance of maintenance of quality of life, and every man should understand like what's important to them, and if they have family, how do they prioritize that? Secondly, always ask questions. Ask, are there other options? Are there clinical trials? Don't get boxed into one thing without knowing all of the specific options. Number 3, I would say, consider genetic testing, particularly if you're very young, less than 50 with prostate cancer, or you have advanced, metastatic disease. Be aware of the clinical trials. And then there's also more advanced imaging that's out now. So, the typical screen or staging for men with high risk or advanced cancer is a CT scan or MRI and a bone scan. But there are more advanced PET scans that are available, like Axemin, PSMA PET scans, which can give very detailed, more sensitive results. And so a lot of that comes from just asking questions and asking your physician. And then lastly, what I would say, anybody who's diagnosed with cancer, you should really consider getting a second opinion. Even if you agree with what your physician said and you trust her, you should still get a second opinion, because you can get more information to inform yourself, help make a better decision, and make sure that you know all of your options that you have available.
Dr. Moses, thank you for this really cool and illuminating conversation. Welcome to our faculty and welcome to our conference.
Thank you very much. Thank you for having me and hope this was informative.
It was. Thank you.